Good morning, everyone. We'll begin our programming in just 1 minute. Thank you. Good morning, and welcome to our September educational call of the Ohio Hospital Association's statewide sepsis initiative. I am James Giuliano, and I serve as Vice President of Quality Programs at the Ohio Hospital Association. Today's program will focus upon a highly effective hospital-wide team-based model for early recognition and early appropriate intervention of sepsis. Joining us on our call today are members of the OHA Hospital Innovation Network, the OHA Statewide Sepsis Initiative, the Post-Acute Care Community, the Ohio Department of Health, and the Health Services Advisory Group. So we welcome all of you. We always begin our calls by revisiting the goal of this statewide initiative, that being to achieve the OHA's board-directed goal of a 30% reduction in sepsis mortality statewide by the fourth quarter of 2018. Before we begin today's session, we would like to just address a few important details. As you know, a vital component of our statewide initiative involves the collection of data. So let me take a moment just to remind our participating hospitals to please be sure to submit your monthly numerator and denominator data regarding compliance to the elements of the 3-hour bundle. Secondly, please know that you will be given an opportunity to type in questions through the chat box feature at any time throughout the presentation. We do encourage questions, and those questions will be addressed at the end of the presentation. Please know that this presentation is being recorded and will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis and by clicking on the education link. There you will find all the previously recorded sessions that do not contain member data. This program has been approved for 1.0 contact hours of continuing nursing education. The OHA Quality Department will be processing the attendance and evaluation forms for web-based programs in a different format moving forward. Beginning with this program, you will be provided with a link to an electronic evaluation tool. You will need to log on, complete the evaluation, and request your certificate. The evaluation process will remain open for 2 weeks following this webinar date. If you do have any questions, please feel free to contact Dorothy Aldrich, and her address is listed on the slide here. We will no longer be utilizing a fax submission option. As most of you are aware, today is Sepsis Awareness Day nationally. On this day especially, we pause to take account of all of our individual and collaborative efforts to reduce sepsis mortality. Here in Ohio, Governor Kasich has proclaimed September as Sepsis Awareness Month, and we are hosting several activities in conjunction with this designation. In particular, on September 28th at 10 o'clock a.m. Eastern Standard Time, OHA will be hosting a live virtual media event aimed at increasing community awareness. We will be featuring a sepsis survivor and his wife, their care team, and our community partners, all who will speak to the impact of sepsis and the need for increased community awareness. It is my pleasure now to invite Tom Heyman, Executive Director of Sepsis Alliance, to offer opening remarks. Tom?
Thanks very much, Jim, and thanks for the opportunity to be with you today. And congratulations on the proclamation from the governor. That's really fantastic. Today is World Sepsis Day, and the entire month is Sepsis Awareness Month. I am the Executive Director of Sepsis Alliance, and we co-founded the Global Sepsis Alliance in 2010, which led to the creation of World Sepsis Day. And in 2011, Sepsis Alliance launched Sepsis Awareness Month. So it's a month-long opportunity to really heighten our focus on addressing the challenges of this disease. We've made a lot of progress. When we got started in 2007 as an organization, public awareness of sepsis was at 19%. And I'm happy to say that our recent survey, we do it annually, shows that public awareness of sepsis is at 58%. So we've more than tripled. But behind those numbers, if you dig a little bit deeper, there's cause for concern, and we're not done with our work yet. Fewer than 1% of the general public can name all of the most common symptoms of sepsis. So we have a real opportunity there to make sure that we improve public education so that they can get to your hospitals more quickly, so that make your job easier to get them out and on their way with a healthy outcome. I will say we are also now trying to track provider education levels and knowledge levels. I think this is an important next step in connecting the dots. And just to share a little bit of information, we have a new partnership with Lippincott, and we've just completed a national survey of nursing community, and really curious about finding out what the knowledge and awareness and kind of facility recognition levels were. And just to share one statistic, which is somewhat startling, is that 69% of our respondents said that sepsis is not a key priority in their facility. So over 2/3 of our respondents, and these are members of the nursing community nationally, said that sepsis is not a key priority in their facility. So we have a lot of work to do, a lot of opportunity, and I am certain that, that's a good segue for me, because I've been working with Andre and the team at Hoag and St. Joe's now for a few years, and really gotten to know the excellence of that team and the quality of their work and their commitment to improving outcomes. And now it's spreading throughout the entire system. So clearly in these facilities, sepsis is a key priority. So I'm really happy to be having the opportunity to introduce that team. And I'll also note that at our Sepsis Heroes event, which is tomorrow in New York City, we will be honoring Andre and the entire team with the Sepsis Heroes Award. So we're really excited about that, and so happy to see this forum where we have the opportunity for the sharing of best practices, which I think this is what it's all about in terms of, achieving excellence in our shared fight against sepsis. So thank you very much, and I'm looking forward to hearing from the team about what their work is doing lately. Thank you.
Thank you for joining us today, Tom. We appreciate your time and endorsement. Our topic for today's call is Code Sepsis Initiatives. It is my pleasure to welcome 3 hospital leaders from St. Joseph Hospital in Orange, California. A recent article in California Healthline entitled "The New War on Sepsis" featured the model of dedicated sepsis nurses. Joining us today from St. Joseph Hospital to share their journey are Dr. Peter Smethurst, an intensivist, Cecile Lamarena, critical care clinical coordinator, and Trish Cruz, director of clinical excellence. At this time, I will turn the presentation over to the St. Joseph team.
Good morning.
Good morning.
Yeah. In California, it's good morning. And to also introduce the rest of our core team, from our ER representation, we have Kristen Merritt-Ball, our clinical outcomes coordinator with the team, our lead hospitalist, Kang Xu, our data analyst with our quality team, Simran Dillon, and Gemma Seidel, our critical care, telemetry, and med-surg family of service executive director, and Linda Bushis, our manager for a definitive step-down unit. And
We can go to the next slide. Okay, so we are St. Joseph Hospital in Orange, California, and that is in Orange County. We're down the street from Disneyland and Angel Stadium, so you have an idea. And we were founded by the Sisters of St. Joseph of Orange in 1929. We're one of the largest hospitals in Orange County. We have just under 500 beds. And we're the first in Orange County and fourth in the state for surgical volume. We have a busy ED at more than 80,000 visits. We deliver about 5,000 babies a year. We have 24/7 intensivists and hospitalists, and we also do psych. We are, as of July 2016, we merged with Providence, and so now we are Providence St. Joseph Health, and that is 50 hospitals in 7 states. And that includes 2 health plans and almost 2 million lives covered. That makes us the 3rd largest health system in the country overall and the largest faith-based in the country.
And an overview of our presentation, we'll talk about our specific ministry's Code Sepsis program goals, building our team and creating engagement for our Southern California Sepsis Collaborative goals that was led with Dr. Vovan and his team, their specific goals, and then the 3 phases that our Code Sepsis response to our dedicated sepsis nurse program encountered, the outcomes from our program in the latest 2 years, and especially some program pearls from our experience.
Thank you for having us, by the way. This is just kind of an overview slide of our overall goals of our program here at St. Joseph's. Obviously, the most important thing was trying to reduce our mortality and the overall sepsis mortality. And a lot of the rest of these go along with that. But we wanted to recognize sepsis earlier to help with the mortality. We wanted to do our best to reduce the length of stay when possible and reduce costs along with reducing the mortality and improving care. And then we needed to close some gaps in our documentation on how we were identifying the patients with sepsis, severe sepsis, septic shock, things like that. We had some bundle compliance issues we wanted to address. We wanted to educate our staff and physicians on sepsis to try to get awareness up, as has been discussed already. And we wanted to try to ensure seamless care. This is one of the active projects we're still on in the post-discharge phase and involving things like post-sepsis syndrome and things like that. So there's a lot of goals overall we were working on in this, and we're still working on it. So I was asked to primarily address some of the educational material regarding physician engagement. And I had given a lecture in the past on that, so I've included a lot of slides from the slide deck from that. And a lot of this is just general information. I don't think it's the biggest thing to discuss in this specific forum. So if there's questions, we can come back to it at the end, and I'm happy to answer anything we can. But I wanted to include that kind of the general information and touch base on a lot of the stuff we did as far as physician engagement. I think that starts, though, with the entire team engagement. When we started this, actually about 8 years ago here at St. Joseph's, the first thing we did was try to think about getting everybody involved to build a strong core team and look at all the potential participants. This is kind of a general list of everything we thought about bringing in, and then we brought forward what we recommended for our team. Let me go to the next slide. Oh, so we have, when we generated our team, we thought it was important to make sure we had nursing from all the major areas of involvement for sepsis. So the ICU, ER. At the time, we did not have a sepsis nurse, but we had a rapid response team here. We call it the MET team. We thought they should be important in there. We wanted nursing administration present, and we wanted pharmacy involved. Obviously, they have a lot to do with the medications and how we get them efficiently administered. We wanted administration involved, and obviously physician teams. So for us, that included primarily hospitalists and intensivists, because we have both of those programs here at St. Joseph's, but we tried to educate and get other people involved as well. I think it's worth noting that part of our team collaborative, even in this scenario, you've asked the three of us, three of the leads within our team, to speak, and we actually have our entire core team here within the room involved in this. And I think that's part of not just part, it's a huge part of our success, is that we have an active, engaged team that is present and contributing at all times. It's not just any one, two, or three of us. It's a whole unit here that we all work together, from administration all the way down to ancillary staff that's involved with the care of these patients. So next slide. So team engagement, this is just a general slide on it. But I think the big thing to do is just try to get everybody involved, try to be receptive, try to be clear, try to be transparent in what the goals are and what we're doing. Some things become limited by how we need to address them due to guidelines that are in place, or order entry systems you may have and things like that. And you got to try to make sure everybody understands what our limitations are and how we're going to work to help you get around those and work with you to implement things that are better. The physician component, to the next slide. So the physician component is important, but it's not the end all to be all to this, obviously. So in our case, we wanted to get everybody involved for the key physicians for our side, which again, we have the luxury of hospitalist intensivists. So that's not true for all medical centers, but if you have those, it becomes a little bit easier to directly engage the people that are generally going to take care of the patients. But even here, we have to make sure that we do have other private admitting physicians that will admit on their own. You have surgeons who may or may not have the hospitalists involved in the case, so they need to also be aware of this. One back. So one of the toughest things with physician engagement is kind of the old analogy of the herding cats. So obviously, we're not always the easiest group to work with, and there are a lot of challenges, especially when things don't always align. There'll be administrative challenges, or in some of the stuff with sepsis, CMS guidelines or regulations that don't exactly overlap with everything we have. So there's a lot of various issues, anything from the multiple hats we wear to other processes and other issues that directly impact us as physicians, that make it sometimes not as easy to get us aligned on the same page. We're all working for the same thing to try to get the patient better, but maybe we have different drivers of what we need to get done, or things we have to address that don't always match up with everybody else. So that brings us to the tool chest. And again, just a list of things that are in our tool chest to address and help with these. And I think this probably the single biggest one to help with this is the involvement and input. So if you want the physicians to be engaged in a process, you need to get them involved and give them input and give them valuable input. Instead of directing them what to do, allow them to give input and how they think it can be addressed. Now, again, that doesn't always work perfectly, and there are things that got to be addressed within that. But to get them in, to give them the input is probably your single best tool. The transparency I also think is important, because again, a lot of time there's things that are clearly being directed by powers outside of the direct care of the patient, and you need to be open and honest what those are, because people are aware that they exist, and when they think they're being pushed in a direction and not being explained what that direction is or why it is, as anybody who's worked with us being physicians know, you'll get a lot of pushback. With regard to the involvement and input, next slide, I think it's important to look into who you pick to be involved. And there's no science to this, there's a lot of art to it, but I think it is important to look at how and why you're going to select various physicians and who you're going to bring into the situation. So the last one out there, the disengaged, there's actually some advantage to sometimes getting the disengaged people involved, because creating input for them in the process might re-engage them. And I think that's important to know. That doesn't always work. There's people who are just, if they're disengaged, going to remain disengaged, but they're one group to consider in the possibility of this, especially if they're creating a lot of your fallouts or issues. But also important, they're trying to find people that are going to be active and give you good feedback and be involved. I think you always got to be careful with having the specific physicians that are giving the input being physician administrators. Physicians don't see them necessarily as physicians anymore. They're administrators now. Yes, they have an MD or a DO, but they're not seen by the active physician staff as wearing the physician hat. So that becomes an issue where they're not speaking from the same position, even though they do have the same training and can recognize a lot of the same issues we have. Along the same lines, I think you got to be careful with identifying, getting the doctors that are always going to agree with what you say. So they're the easy ones to have in the meeting involved with you. They're the ones who often get called to the meeting because they don't give a lot of pushback. But the people who always say yes are either partially disengaged, in my opinion, or they're looking to be the admission physician administrators. People are going to give pushback because they care. So that's another balance you have to be involved in. And then the other thing I'm commenting on, there's too many cooks in the kitchen. There's always the fine balance. And the same thing with our entire team of trying to get everybody involved, but not too much of everybody. As soon as you have, one doctor in the room, they get to be the decider. You have 2 in the room, it might work. You get 5 in the room, as you know, you're going to get pulled in 5 different directions that may or may not overlap at all. So you got to be careful, and you always want to find that balance. Obviously, this is a difficult topic that's a lot more art than science involved. Next up was transparency. I mentioned that earlier, and I think it's just important to make sure everybody knows what's going on and how we're doing it, why we're doing it, and the importance of it. In this case, it's easy because it's the primary driver is saving lives on one of the, and arguably the most important disease within hospitals. And I think just making sure you're transparent about any other outside pressures you're addressing and why you're doing it, I think raises your credibility. Next up, education. I think there's a lot of tools there just listed, things like that. One that I particularly like to, next slide, like to try to get, if you can, within your EMR. They seem to be locked up here on our slide screen. If you can, I like the idea of education embedded within your EMR. So it's something we worked to try to create here a little bit. Because it's a quick link while people are actively making decisions, but all the other ones, grand rounds, meetings, here we have medical staff briefs, things like that that can help educate are also important. Next.
We're having a
problem advancing our slides here. So next up is support. I think that's also key for the physician engagement and for the overall team. So you want to make things as easy as you can within these kind of protocols, within how we're going to get things done, how we're going to have things available to physicians, who can help them. This is where things like our sepsis nurse become immeasurably valuable. It's hard for the physician to know some of these, they're busy doing admissions. It's hard to know when your 3-hour and 6-hour timeline is running. So if you have staff, be it the nurses at the bedside or a sepsis nurse that can help a physician know it's time to do your follow-up documentation or make sure the fluid bolus is completed by such and such time, that's infinitely helpful. And I think it's one of the things that made our process here so successful, and the support that's been given to us by our hospital and the health system in getting sepsis nurses has been huge. Lastly, in physician involvement and trying to help them is always the things in the toolbox to think about regarding incentives and alignments. All of those are going to be variable based on the hospital institution and what you have as options within your state, within your hospital, fundings and things like that. But there's contractors, contracts, directorships, employed physicians, things that can help along those lines are always important. And I think it's worth noting that a lot of people involved, a lot of the things we're doing within these processes are not directly related to what the physician would normally consider their job. So even little stuff like the CMS recommendation for a follow-up documentation, we get a lot of pushback from doctors on that because, you know, I'm following up all day, I'm consistently following up. It's extra work would be the statement to do this extra documentation. So we have to find ways to help encourage them to do that and get involved because it's, you know, they're doing something that's good care, but not necessarily part of their actual work and actually inhibits the work and care of other patients to do this extra documentation when really, you know, in the case of our hospitalists, certainly in the case of our intensivists in the ICU, you know, we're not doing one follow-up that gets to be the documented note. We're doing serial follow-ups throughout the next several hours of this process, and it's felt to be extra time. So if you can get things that can help with that, it's also very important.
Okay, so thank you, Tom, for bringing up Dr. Andre Vauvin, because he was the team lead for our Southern California collaborative within our health system. And so that involves 5 hospitals or ministries, as we call them, from within our health system, and that was St. Jude in Fullerton, Mission in Mission Viejo, St. Mary's in the High Desert, also known as Apple Valley, and Hogan, Newport Beach. And what made bringing these 5 hospitals together very, very helpful is exactly what you guys are doing on this call, and that is the collaboration and knowing that you don't have to pilot everything yourself, that you can have your friends and relatives pilot for you. So if you can have other hospitals in the area perhaps trial a particular or pilot a particular checklist or whatever that might be, that's helpful. So again, I'll remind you of the phases that we went through and are going through.
If we can advance the slide, please. We're not able to control on our end.
Yes, if you could, well, I'm actually in the next slide, so thank you. We're having issues on our end advancing slides. But again, so phase 1, as you can see up there, again, ministry meaning hospitals within our health system. So what we did is we looked at the existing processes within all the individual ministries, and we thought that we would focus on standardizing sepsis protocols, and that includes order sets. We went from 36 order sets down to 2, so that was a huge win for us. And those order sets really involved the 3- and 6-hour bundles. We looked at the idea of possibly a sepsis coordinator and what that role might look like, whether or not to have sepsis nurses, and are they 24/7? How did that work? What is the team like? And then we tracked everything regionally. And then we moved into phase 2, which was really about after the 3- and 6-hour bundles and where the patient went and how the patient flowed through the system. Phase 3, we are actively working on now, in addition to the other 2, and that's really more around a safe discharge from the hospital. And so not only is that to prevent readmissions, but it's also to address the needs of patients in the post-acute care setting, looking at post-sepsis syndrome, but and also looking at end of life. So there are those patients that, despite all of our care, that still have a grim prognosis and are not expected to live. And we do have a palliative care team, and we're able to do some advanced care planning with these patients and perhaps align their care with their desires at end of life. So next slide.
So for the past couple of years, our Code Sepsis program has been reevaluated, revamped, and one part was starting to bring back the Code Sepsis response in the ER. Over the previous years, we've had a Code Sepsis response on the inpatient side, but exploring what would be our next steps in taking our program to the next level. So one part was remapping the new process, and that's what we were doing in the middle of 2015. We had conducted a 4-day pilot in July, looking at just the workflow from our rapid response team, doing a Code Sepsis response in the ER, for our ER team, screening every ER patient that's coming in through the triage area, in addition to early identification and early communication to the ER physician and to the rapid response team. It required education for our ER, our ICU, and our step-down unit, and for our MET team that will be doing the responses. We were also revising our current order sets at the time to align with the CMS measures that were coming out in October of that year, along with our revision of our rapid response team documentation. And at that time, also furthering alignment, like Dr. Smethurst has spoken about with our team engagement, was creating our Code Sepsis core team and even a work group for more of our global decisions for the hospital. Our phase 2, just branching off the start of our Southern California Sepsis Collaborative, was also looking at not only keeping our MET team whole and keeping them on the inpatient side, but also championing a separate rapid response team nurse that will follow our patients starting in the ER and towards the inpatient. So we had piloted a 12-hour shift sepsis nurse starting in January of 2016. We had 6 of our MET team nurses branch off and do this pilot. And during that time, we had done a time study and looking at when were the core times of our sepsis patients coming in through our ER. And that was during 8 in the morning to midnight. So plugging into a 12-hour time frame, we were starting with a 9 to 9:30 shift. For our sister hospital, Hoag, when they were trialing their sepsis nurse, they actually had a different time frame from 11 to 11 p.m. For our sepsis nurses, they had facilitated the 3- and 6-hour bundle completions, collaborating with the ER team when they're called for a code sepsis or even a sepsis consult. They would follow the patients for the initial first 24 hours of being admitted to any of the med-surg floors outside of critical care. During this time, we were working with our other ministries here in the Southern California region, aligning our physician documentation, all of the order sets, drilling down to 2, and even revising our ER nursing documentation. Phase 3 started in July of last year, where we were able to get administrative support for having our sepsis nurse from 12 hours to a dedicated 24/7, along with our 24/7 dedicated MET nurse. During this time, they'll still continue their sepsis, code sepsis response in the ER, along with any sepsis consults. With the assistance of collaborating with the ER team, they also are utilizing more technology during at this time, where they have a high alert app that with any patients with any specific sepsis triggers will alert them to their smartphone. Also with patients where there might be concern with the fluid resuscitation, they're utilizing the non-invasive cardiac output monitoring device. During this time, at the beginning of this year in 2017, we also rolled out a house-wide caregiver education to all modalities. So not just ER, not just ICU, but our inpatient nursing, procedural areas, and even women's services. And expanding from education, we also collaborated with our patient and family advisory council for patient and family sepsis education, in addition to starting more of our preventing sepsis readmission program. Next slide. So one of the decisions that we had to make as a site and as a team was looking at where we feel we needed to invest in resources. Is it a sepsis coordinator? Is it a dedicated sepsis nurse? Ideally, we would like to have both, but sometimes it's not always that way. The coordinator role was actually elements that we've acquired over the past 8 years. So monitoring compliance of the guidelines, the CMS bundles, our quality team, and our weekly code sepsis subgroup that's looking at all of these cases going to critical care, monitor that really well, along with the patient outcomes that, or for all of our sepsis patient outcomes, along with creating education that aligns for all of our caregivers, and even networking with different hospitals and even health systems, communication and global facilitation. But for our site, we also wanted to explore bringing the sepsis expert not just at a global level, but at a local level, and especially locally with the patient. So making sure that there's an expert with evidence-based treatment guidelines with the patient at the bedside, collaborating with the care teams that are working with them, facilitating early goal-directed therapy and compliance, providing real-time education, not just to caregivers or providers, but to patients and families themselves, and following this patient across all the departments. Next slide, please. So one of the tools that our sepsis nurses would utilize, especially with tracking any of their sepsis calls, is their sepsis RN checklist. This is currently a paper tool. We're working with our health system in creating this to be an electronic tracker, but it's capturing time zero, where the patients are being identified, when they're being called, the type of call, from anywhere from order sets to any of the 3 and 6 hour bundle elements, and even it's utilized as the tracking tool when there are proactive roundings on our patients. And they proactively round on our patients within the first 12 hours of first being admitted to the med-surg department, and then a second 12-hour proactive rounding. Next slide, please. So one of our other tools that are utilized is sepsis SBAR report from our ER nurse to the admitting nurses, letting them know what are the 3-hour elements completed for the patient, what's been done, if there's anything outstanding that still needs to be continued over, if there are 6-hour elements that needed to be completed or needed follow-up. And then also making sure that our sepsis nurses have been notified for this patient, and especially if they're being admitted to a unit outside of critical care, making sure that they're still in the loop for the care of that patient. Another education piece is for our inpatient, in knowing the roles of both for our medical emergency team nurse and the sepsis nurse. For our medical emergency team nurse or MET nurses, we wanted to keep them still on the inpatient. So for any patients that are a new sepsis or a positive sepsis screen, since we screen all of our inpatients each shift, if any of those positive severe sepsis screens have occur, there's something acute and new, then it's a call to our MET nurses initially to work them up, triage if there's any issues that needs to be addressed right away. If there's still any proactive rounding on that patient, then it'll be the sepsis nurse that will continue proactive rounding on that patient. And for our inpatient nurses to be aware that there's a second rapid response team nurse that will be following their patients once they're admitted from the ER. And here's a snapshot of our sepsis patient education tool. It's an 8.5 by 11 handout that's provided to the patients and their families that outlines specifically what is sepsis in layman's terms, and also the type of caregiving teams that will be following them throughout their stay.
So how do we do with all of this? We're a little locked up right now, but I can tell you that we know that process drives outcomes, and so when we look at our actual compliance to the sepsis bundle, and we look at it from 2016 up through the first quarter of 2017, that we're averaging 70 to 80%, sometimes even a little more than 80% compliance with the bundle elements. And again, this is an all or none score, so meeting all of the SEP 1 requirements for both the 3 and the 6-hour bundles. Next slide. And this slide shows the progression of simple sepsis to severe sepsis and septic shock. And so since 2014, you can see that we've had a very favorable downward trend in the progression, again, from simple sepsis to severe sepsis and septic shock. And we attribute that to our early goal-directed therapy. And this shows our length of stay. So by treating patients earlier, we were also able to decrease their length of stay. And since 2014, that's almost 2 full days decrease in length of stay. And this shows our variable cost per case. So since 2015, again, we've had a dramatic increase in the cost of care. And that's not just because of the decreased length of stay. It's, again, because that early goal-directed therapy prevented patients from progressing to severe sepsis and septic shock. And it also then eliminated the need for all those additional treatments and services. And this shows our mortality data. Again, a very favorable downward trend in our mortality. This shows almost 50% reduction in our mortality rate since 2015. But in fact, in 2014, our mortality rate ranged from 28 to 30%. So this is a dramatic decrease in mortality. And that next slide, and that decrease basically equals 747 lives saved since 2014.
So some pearls and lessons we feel we've learned along the way. One piece that Dr. Smethurst emphasized on is establishing a core team of champions and stakeholders leading the effort and making sure you have everyone at the table and everyone has a voice to provide feedback and also to champion along the way. Another piece is establishing and supporting a rapid response team infrastructure. For us, it's a pool of dedicated ICU nurses from our ICU pool, and making sure our team is strong and has the tools with policies, standardized procedures, aligned rapid response team processes, along with documentation. Making sure there's frequent and consistent communication. So education is key. And interdisciplinary collaborative meetings that are frequent for our team. We meet twice a month. We also have our quarterly work group meetings as well, meeting with our administrative teams, and outcomes monitoring that's concurrent as much as possible, making sure we're providing meaningful feedback in real time to our providers and caregivers teams. And also what we felt was probably one of the most important aspects and pearls was the code sepsis and the sepsis consult, just the alert, the communication, the collaboration between our ER team with our sepsis nurses, with our providers, and our caregiving staff. That's the part that's mainly key. No matter what tools that you have there, just that collaboration piece is the ultimate tool.
Okay, so we can see that we have a question. So what screening tool are you using for initial identification of possible sepsis? So do you want to talk to them about our tool?
EMR-based nurse input versus pooled data from EMR predictive analytics.
There's currently no predictive analytics in our screening tool. It is embedded within our electronic medical record. It is nursing based on the in both the ED and inpatient side. Do you want to talk to them about some of the questions on there? On the screen itself?
On the screen itself, through our ER team, they ask, do you want to chime in?
So in the emergency room, the triage screening tool includes questions relating to suspected infections. So recent procedures, surgeries, cough, fever, and then based on vital signs entered and Sears criteria, including altered level of consciousness and recent fever, the screening tool will score based on those criteria.
Yeah, basically the ER triage has a tool we've developed. It was originally SIRS based, and since Sepsis 3 came out, we've added the QSOFA things to it, though What's worth noting, we primarily follow the SIRS just because that's how CMS categorizes all these things. So it's kind of a tough thing to balance the two of them right now. So we've kind of tried to incorporate both in as a potential screen. And then on, as Cecile mentioned when she was speaking, on the floor patients, so a patient who was maybe admitted with an MI or something else that wasn't sepsis, we do every shift, there's a screen for SIRS is what we currently have. And if you have a patient who's at risk, then that's when the MET nurse, not the sepsis nurse, the MET nurse gets notified of the positive screen, and then they look at the thing to see if it should be on the sepsis nurse's following and notify any physicians that might be involved in it. In addition, we've also have a tool that can use some of the information from the EMR that can alert us from an app that identifies some of the patients that might meet SIRS criteria or a positive lactate. And again, that will notify our MET/sepsis team to get involved and follow up on the patient. So we have multiple layers of screening tools. And obviously the primary one where most of our patients get identified is the emergency department. And hopefully most of those are identified at triage. So obviously some patients aren't initially identified as potential sepsis, and then if a physician decides it's sepsis, we would then get the sepsis nurse involved. But we've kind of tried to create layers of redundancy in it so we don't miss cases.
And we've had a sepsis nurse and rapid response nurse join us. So would you like to add anything to what Dr. Mathis just said?
No, I really appreciate using the electronic iodine app as well, in case it just provides another net for us to be alerted to a potential sepsis case in the ER, at which point the sepsis nurse themselves can come and talk to the ER nurse and ask if it's appropriate to begin sepsis pathway. So like you were saying, just creating redundancy so that everyone has an alert and a way to be possibly included in a case that could potentially turn into a sepsis case.
Do you want to hear about any differences between our women's services sepsis screens and our med-surg patients?
That has been a very hot topic lately about obstetric patients who are in active labor and could potentially be septic. So we are working right now, Cecile could probably answer this better, with different SIRS criteria to help us answer the questions better. I know as a sepsis nurse, if I'm called about an obstetric patient, I immediately talk to the attending to go through with them so that we would never initiate any part of a bundle with that kind of patient population without talking to them as experts in their field. But we are working on, as I understand it, new SIRS criteria to help us.
Yeah, so there's some data out there regarding, because obviously some of the SIRS criteria would be normal in a pregnant woman, especially one that's peripartum. So there's some data out there to suggest, so for example, I think the heart rate for a OB patient would be 110 as their trigger and things like that instead of 90. So there's little things like that that we modify for our alert for those kind of patients, which is, again, is something we've been actively working on in our collaboration of trying to identify patients early. We've been spreading out to other departments. OB is one. Cancer Center is a place we're currently working on. So patients in our transfusion center, if we can get early alerts for those patients that are potentially at high risk, kind of as our effort here to expand our net that can catch all these patients again. One of the big things we can do to reduce the mortality is identify them earlier and prevent the progression from simple sepsis, as we like to call it here, so that we don't get confused with just the word sepsis. We call it simple sepsis. We try to prevent progression from simple sepsis to severe sepsis, and obviously that's good for the patient, it's good for patient care, it's good for the cost, it's good for length of stay, it's helpful in all fronts. Any other questions?
Well, thank you, Peter, Cecile, and Trish, for your detailed presentation, your slides, and for sharing your resources with us. And I, at this time, would like to invite participants to submit any questions they may have through our chat box feature. We'll be glad to address those with the team. Also, for the other members of the St. Joseph team that are in the room, thank you for your time and your willingness to be there today with us. One thing that I did notice was that communication among all levels of providers and departments is really an evident priority for you as you've gone through your model. That we get the sense from what you're saying that people are connected, staff are connected, healthcare providers are connected. And that is so very important. And one way that you articulated that was by talking about all the early alerts that you placed that you put in place with the various multiple levels of patient care, like inpatient, ambulatory in your infusion center, OB, med surg, and so forth. So I think those are all very crucial. We do have our first question is for the inpatient, for the inpatient sepsis screening tool every shift. If patients screen positive, is the MET RN that responds able to order any elements of the 3-hour bundle conditionally or by protocol?
Okay, why don't we have our met nurse want to respond?
Yes, we have a protocol that allows us to draw some initial labs, and based on the patient's condition or medical history, we will ask the fluid boluses we do not necessarily give unless the lactate, correct me if I'm wrong, is above 2. I don't have the protocol right in front of me. So we would talk to them along the way and say what we found through the lactate, what we found through the white blood cell count, and go over the search criteria with them. And some of the screening tools are we're able to look at the patient and talk to the bedside nurse and find out that in fact that patient doesn't have a suspected infection. So some of the search criteria are then irrelevant. So we're able to kind of play the first line of investigation.
Yeah, we have protocols in place that are basically what we call standardized procedures that allow some of these initial assessments to be initiated by the nurse, and that's generated from nursing recommendations from our committees involved in this particular case, but other standardized procedures become from other collaboratives, and then it goes through the medical staff for approval. And in this case, their ability to check some initial lab studies of maybe a blood gas, the lactate, and give an initial fluid bolus as part of their standardized procedure that they're allowed to be involved in while we're working on getting other physicians and providers involved.
Thank you. And so you mentioned in your presentation that particular dedicated sepsis nurse is an expert in evidence-based guidelines. And when you did the comparison between the coordinator role and the dedicated role, that was something that really, was made clear. Can you talk a little bit about what type of preparation educationally that dedicated sepsis RN goes through to become that evidence-based expert in the guidelines?
For our sepsis team, they do get, when we had first initially taught the entire rapid response team, that it was education on sepsis itself, and it's been that way over the years, along with the CMS bundles, what those items would be, and then education on the workflow, communication, workflow of with the ER team, with the inpatient caregiving teams as well, and in addition to communication with our providers, if a patient's screened positive, other education parts for their training, for their role would be managing a patient in an emergent situation, how to utilize their standardized procedures. In addition, if there's any barriers that they're encountering, how to communicate back to the team, let us know. And we do meet with our MET and sepsis teams every month now, that we meet with them, along with kind of ad hoc coaching meetings with, especially with Dr. Smethurst, if there's any items to route back with him for feedback from a provider standpoint for the team.
Yeah, so the education is given via, we have lectures, we have online available lectures, like sepsis talk I gave here, things like that. They have a skills day here that all of our ICU nurses go through as part of their training, so the sepsis nurses get involved in that. And then as Cecile mentioned also, they have their monthly meetings where they give updates, any questions, new issues, if there's new CMS guidelines like the ones that are just released, they come out, things like that. And then we actually give direct feedback to them as well from our reviews of cases if we find things we can do better or where we're maybe having fallouts or what issues are coming up. We do direct education, sometimes one-on-one, sometimes we gather the team with either an ad hoc meeting or one of their regular meetings to, again, update them on any changes or things we're seeing in-house as far as issues. So it's kind of an ongoing, continuous education thing with a few consistent components like the skills day and lecture-based things.
Additionally, they've given us, this is the sepsis nurse, additionally, they've given us a binder which is continuously updated with any new guidelines, for instance, the new antibiotic guidelines, and we also have in this binder references to every situation we could need to go through, the SPAR2, the QSOFA, and this is, I feel like, a very valuable resource for us to have hands-on wherever we are in the hospital.
We want to address a couple of the questions that have come up here too. So we have, has anyone used team steps to implement better communication? And I can tell you that here at St. Joe's, we use crew resource management, and that is very similar to team steps. And we are very fortunate in that our patient safety officer who teaches this course with 2 physicians has a background. She used to be a flight attendant, so she's done the crew resource management actually in the airline industry as well. And that is mandatory for our all of our procedural areas and highly recommended for all of our staff and physicians, and is very well received. And we've even, I mean, it's amazing, we've even had EVS people in the class, and now they wear buttons, and they've taken upon themselves that they made these buttons and that say, "We save lives." And so, again, very well received.
And the next question is, how are the code sepsis and sepsis consult alerts called for our patients that meet severe sepsis septic shock criteria? And it could be anyone that can call, either the primary nurse for that patient, the provider, and it's a direct call to our sepsis nurses. In the ER, if it's a severe sepsis septic shock patient on the inpatient floor, it's a direct call to our met nurses. Sometimes if they are really compromised, it would be an overhead call for them on the inpatient. The sepsis consults are direct calls to any of our rapid response team. If a patient is, hey, somebody is starting to meet some criteria, we're still doing a workup, there's a possible infection for this patient, you probably want to put this patient and start tracking them. That's just a heads up and a communication to our sepsis nurses.
And some of the hospitals within the health system actually have it. It's in the order set itself that a call be directed to the sepsis nurse. Some of the hospitals and health systems, though not us specifically yet, have made it so a page goes directly out, and that's via the actual EMR and Meditech for them. For us, what we do is we have, as an order, go to the nursing to make sure they call. Sometimes it's the doctor, sometimes it's, like I said, the sepsis screen. But it does have Meditech at least does have the ability to generate an alert directly by initiating the order set, which is actually one of the key things, I think, when the order sets are generated, trying to make everything as automated as you possibly can. And that's even within the education, like I had mentioned, if you can embed stuff within the EMR and make it easy. So our order set actually for sepsis has antibiotic recommendations within groupings based on the diagnosis. So you'll have, there's a category intra-abdominal, there's a urinary tract infection, there's CNS, and we actually update those routinely based on our antibiogram, what our recommendation from our stewardship committee would be for the initial antibiotics, and we keep those up to date. And those little things like that are helpful. Again, make it easy for the doctors to do the right thing, to get involved. We educate them as much as we can, but if we give them the tools to do this, it becomes much easier, and I'll have little recommendations you can use within various EMRs. I've seen where you can identify, they'll have a little globe or an eye symbol for information. You can click on it and give you some background information on how that's applied. And if you can get those tools built into your EMR, it becomes a one-stop shop for your sepsis care, which makes it that much easier for your providers and for your staff to help do the right thing.
Okay,
Thank you. I'm sorry. We do have another question, and it is, did you include the QSOFA in the inpatient screening tool, or was this only in the emergency department RN triage sepsis screening? And then did you adjust SIRS criteria for heart rate and respiratory rate for the inpatient screening tool as well?
For the inpatient screening tool, we will be including QSOFA. We're going to keep the SIRS criteria as is that we had previously used, but we're just adding the QSOFA element with it. If a patient is suspected for infection and at least 2 of the QSOFA elements are also present, then the patient's also flagged for severe sepsis. And it's still pending for the ER triage sepsis screen to be updated with that as well. For our code sepsis in our cancer center, they are utilizing QSOFA as the screening in their infusion center, since they wouldn't readily have labs available right away.
And the really big thing that QSOFA adds to this whole process is the altered mental status. And we actually included that in our original screens before that all this QSOFA information came out, because it's one of the markers for just general severity of illness that can help us identify these patients early. And so that's probably the single biggest thing that QSOFA adds to our screens, both the inpatient and outpatient side. We try to make sure everybody is aware that if a patient is altered, we have to start thinking about the possibility of sepsis.
Thank you. Well, the presentation has been phenomenal, and you certainly have highlighted how you've decreased progression from what you term simple sepsis into severe. You've decreased length of stay. You've demonstrated a decrease in cost per case, but most importantly, you've noticed a decrease in mortality measured in patient lives. And for that, we are grateful for you and your willingness to share with us today. For those of you who have joined us, thank you for joining us. As a reminder, our next call will be held on Wednesday, October 18th at 11:30 a.m. Eastern Standard Time, where we will hear from a team at the Cleveland Clinic. Their presentation will provide an overview of their model for conducting sepsis case reviews. We look forward to having you join us on that call. And this concludes today's call. Please have a great day, and thank you again.